I'm Dr. K. Agarwal. Today we have with us Dr. Shashank Rai Gupta, who is a vitreoretinal surgeon and ophthalmologist, and he is the head of and the founder of Delhi Eye Care in the city of Delhi. So Dr. Shashank, when we talk about diabetic retinopathy, at the end of this 20-25 minutes, I would like to end up into what are the 10 points where every GP must know on diabetic retinopathy. So if I have to say one most important thing in diabetic retinopathy, and it is, we always say look for complication at the time of diagnosis. So we are saying is that diabetic retinopathy, at the time you diagnose a patient with diabetes, you refer him for a retinopathy checkup.
Definitely, yes, sir.
Do we have enough number of ophthalmologists in the country?
We have, sir. Nowadays, the scenario has completely changed, and so many vitreoretinal surgeons are coming out. And in Delhi itself, I can know that there are more than 150 vitreoretinal trained surgeons who are coming out of fellowships. So there is no dearth of diagnosis, no dearth of trained vitreoretinal surgeons in metropolitan cities at least. But now smaller tier 2 and tier 2, 3 cities are also having these kind of services. If not permanently, at least once a week, most of the cities are being covered by vitreoretinal surgeons.
So if I have to go back and, because we as MD physicians are being told that if microalbumin is negative, retinopathy is absent. And microalbumin test costs only 80 rupees.
Also, we have, like in clinical scenarios, we have seen that we usually get the microalbumin done if it has not been done by a physician already. And most of the patients are not positive of microalbumin, still they are having diabetic retinopathy. Maybe the stages are early, we can catch them early, and then we can guide them accordingly that how quickly and how frequently they should follow up, so that they don't develop the further complications of diabetic retinopathy.
So suppose if diabetic retinopathy is absent at the time of onset of diabetes, what next advice we give? Come back after how many years?
After a year, sir. After 1 year. If there is no diabetic retinopathy, then the next follow-up is scheduled after a year.
So if I am going to come back with a statement that the day a diabetic is diagnosed, for the next 70 years, every year he need to go to an eye surgeon or a eye ophthalmologist, it may be a little too much as a IMA policy. So therefore I need to train my GPs so that they can refer the person to a specialist only when there is an indication for an intervention. For a routine follow-up, we need to come out with something like a screening. Screening by a specialist cannot be an IMA policy.
So the screening can be done by most of the ophthalmologists also. Now
When I say ophthalmologist, he is a specialist for me.
So for that, now the telemedicine has come up in a big way. We have got a very cheap fundus camera which can be implanted in every physician's clinic, where they can just click the photograph and send it across telemedically to the ophthalmologist or vitreoretinal surgeon, which they can screen and then call them whether the patient has to be seen in their clinics or we can just follow them up through the telemedicine.
And that's what IMA policy also is. IMA is recommending that all clinics and should have a camera for taking out a fundus examination, so that at the same time can be evaluated by a person who is an expert in that. So one is the diabetics annual eye screening, that's one. 2, annual microalbumin, which is endothelial dysfunction, which will tell the patient has nephropathy, likely to be a cardiovascular disease, and likely to have a retinopathy. That's 2. Number 3, how is the retinopathy linked with control of diabetes?
Definitely, yes, sir. This is the most important point. Hyperglycemia is very well correlated with diabetic retinopathy and subsequent development of diabetic retinopathy. So every 2% is increase in HbA1c leads to 2 times increase in the incidence of diabetic retinopathy.
So to prevent diabetic retinopathy, what is an ideal HbA1c levels?
So ideally we tell that HbA1c level should be less than 7%.
So the third point which has come is, 1 is annual screening, 2 is yearly microalbumin, and the third is keep the HbA1c levels less than 7%. Normal is 4.4 to 5.5%. 6.5 is the diagnosis. More than 6.5 is diabetic. Less than 6.5 is impaired glucose. But if the levels are more than 7, it can impair and it can worsen retinopathy. So keep HbA1c level less than 7%, ideally 6.5%. These are the third point. Fourth point.
Then, sir, there are very many conditions which has to be controlled along with the sugars. That is, hypertension has to be very well controlled. Serum lipids has to be looked into. Hemoglobin level has to be linked into. All these together can lead to development of retinopathy. Even if the sugars are well controlled, patient is having hypertension, patient is having higher lipids, patient is having anemia, they can still progress to diabetic retinopathy.
So what Dr. Shashank has said very clearly is that don't treat the figure called blood sugar. Treat the patients, and when you treat the patient, look for A, B, and C. A for A1C, B for diastolic blood pressure, keep it lower than 80, and C for LDL cholesterol, bad cholesterol, and keep it less than 80. So fasting sugar less than 80, lower blood pressure less than 80, and LDL cholesterol less than 80. That should be your target to reduce chances of both microvascular and macrovascular complications of diabetes. So fourth is that don't only control blood sugar, but also control the lower blood pressure and the LDL cholesterol. Next.
Again, there are certain other situations that we need to take into. Obesity is another factor that we need to look into. Pregnancy, we can develop diabetes. Alcoholics are more prone to this. Exercise, those who are obese and not doing exercises are again prone to this. So we have to look further than ABC and then go to diet, exercise, and all these factors also.
So the next fifth point comes is that you look for associated other risk factors, and like smoking, like alcohol, excess of alcohol, like smoking, like overweight or obesity, faulty dietary habits, low hemoglobin. So look for other factors which can also impair diabetic regulation as well as precipitate diabetic retinopathy.
Next is that we need to see that patients are being seen by ophthalmologists. Most of the time physicians do refer them that go and get it screened. But they either don't go because they don't have a problem, the vision is 6/6, they say it's not necessary. But most of the time, diabetic retinopathy, when it starts, it initially doesn't impair the vision. So it is utmost important that we catch the patient.
My thing is that early diagnosis is fine, but what is the early treatment? Early diagnosis is fine. Then if there is an early diagnosis, what is the early intervention which can help?
The early intervention, if there is no macular edema, if there is no diabetic retinopathy up to the level of high risk, we generally don't treat. We just enforce them that they control A, B, C, D, as we already mentioned, and with the frequent follow-up with the physicians. As and when the vision starts impending, either because of the diabetic macular edema, which is the swelling comes into the center of the retina, or they develop complications like neovascularization or bleedings or tractions, then come the roles of the lasers. And
my question is very simple. When when a person is symptomatic, he will go to an eye surgeon. I don't need to tell to my GP.
Right.
If my GP or a physician knows the patient is having impairment of he has eye symptoms, automatically it will be referred to an eye person.
Right.
I'm talking about asymptomatic patients, asymptomatic diabetic. At what stage he may need an intervention?
Sir, asymptomatic patient need intervention at the time when the neovascularization starts.
Can that be asymptomatic?
It can be asymptomatic, sir, because initially they don't lead to bleeding and it forms in the mid-periphery or the peripheral region. So at that time, if we catch them early, we can just do the lasers and save the vision. That is very important.
So the next point comes is, point number 6 is that it is possible for you to have changes in the retina because of diabetes without any symptoms, which may require intervention at that particular moment. Now, how slowly it progresses, these changes, so-called early neovascularization, which needs a laser treatment, if not done, how much time it will take to become symptomatic?
Sir, again, it depends on the control of blood sugar. If the sugar control is...
with sugar control, we are assuming it. If the blood sugar is controlled, obviously, if you diagnose a patient with early neovascularization, we expect that tight blood sugar control is being done. Will that say, why I'm asking is, like you take it in carcinoma of the rectum. It takes 10 years for the adenomas to develop.
Right.
It takes another 10 years for adenomas to become ulcerative and shed their cancer cells in the stool and become occult blood positive. Okay,
Right.
Then it takes another 10 years. So it's a process of within 20 years. Anytime you can diagnose and pick up CA rectum. So he says CA rectum is curable because the window is 20 years. So is there a window of retinopathy that if you So suppose there is a window of 5 years, then everybody gets a chance. But the window is very, very small. Then the emphasis has to be that nothing doing. Eye checkup has to be done.
So, if the stage is already in the high risk PDR, high risk retinopathy, then there is no window.
What is the high risk?
High risk is proliferation. There's a neovascularization formation. We say that if the patient is under 5 years of diabetes, the incidence of having retinopathy which has to be treated is 20%. But if the patient is having sugar for last 15 years, that incidence goes up to 80%. But if the patient has been coming asymptomatic with new vascularization, lasers has to be done immediately because it can bleed any time.
So yeah, new vascularization, irrespective of symptoms, is the point.
Yes,
So that means every GP and physician must know in diabetic, is my patient having new vascularization? So now new vascularization can be detected by fundus?
Yes.
Okay.
Yes, it can.
Can be done by anybody, by fundus, by the low cost fundus care and take a photograph?
If good fundus photographs are taken, it can be seen, sir. It can be seen, but it has to be referred to the ophthalmologist or the trained persons.
So that is like an ECG. You take an ECG, send it to a cardiologist, he can report.
Yes.
It becomes like that. No? Every GP is sending ECGs for reporting.
Yes.
Similarly, GP can send a fundus. How much does fundus cost?
Fundus camera, sir?
Yes.
Fundus camera is now costing less than 1 lakh rupees, 2 lakh rupees. Now these mobiles can also take good fundus photographs.
How?
The patient so there are certain systems which we fit into this mobile camera, and then they are subsequently fit into the slit lamps. Then according with them, they can take the photographs.
No, but then you require a slit lamp. I'm talking about a GP, how will he do it?
No, GP cannot take it with the photograph, the mobile phone, sir. It has to be fundus camera, which costs somewhere between 5 to 8 lakhs.
So what I'm only trying to say is that an investment of 5 to 8 lakhs. See, we are talking about 130 crore people. 10% of them will be 10 crore people suffering from diabetes. And I don't have a ophthalmologist.
Right.
So I can't talk about screening. When I'm talking about an IMA level, I'm talking about at a pan-India level. So in a pan-India level, because I know our IMA program, they have catering to a fundus which is very fundus camera which is very cheap. There are people who are developing it. So we need to come out with a fundus camera which we need to endorse from IMA, which every GP clinic can have.
I completely agree with you, sir. But at the moment, good fundus cameras are in the range that I have told you. But there are so many people, so many ophthalmologists also are in the field of developing low-cost, cheap cameras which can then be passed on to the physicians to catch the diabetics early. As of now, the cost is what I have told you.
Okay. Any other point in retinopathy we need to know? So one is laser. Yes. Apart from laser, is there any other treatment?
Yes. So now the most important treatment is based on intravitreal injections. These are of anti-VEGF agents, be it Avastin, be it Lucentis, be it something else. These are known as the wonder drugs. Be it macular edema, be it neovascularization, these are used. But the only drawback is that it has to be used multiple times, it has to be used on a monthly basis. There again the education comes. Patients certain times drop out of the treatment, then they face the music in the later part of the life. What we tell them is that aggressive treatment has to be done the initial part of diabetic retinopathy when it is diagnosed and when it reaches the stage where we have to treat it.
If I don't treat diabetes, how many percentage of them will end up into blindness?
Sir, if we don't treat diabetic retinopathy, 30 to 35% will end up in blindness.
And if I don't treat diabetes, how many of them will develop retinopathy first?
If we don't treat diabetic retinopathy, as I
No. If I don't treat diabetes, how many of them will develop retinopathy?
Almost 100%, sir.
In 15 years?
Almost 100%, yes.
Okay. So the message is that if you don't treat diabetes, 100% will develop retinopathy by some age, maybe more than 15 years. And if you don't treat diabetic retinopathy, 30 to 40% of them can become blind. Therefore, IMA feels that today or tomorrow, it will be a professional misconduct. Somebody will come back and say that I developed retinopathy because you did not manage my diabetes well. I don't mind that every diabetic management may end up into a contract. There will be a contract between the physician and the patient regarding diabetes management, because sooner or later patients are going to sue the medical doctors that because of you did not told me, or you did not give me intensive treatment, or you did not control my A1C, therefore I developed diabetic retinopathy. My another question, that if I control my diabetes, keep it below A1C less than 7% throughout my life, what are my chances of developing retinopathy?
So then the chances are less than 5%. If we control the sugar levels well, associated with all other systemic parameters which we discussed previously, then the chances are less than 5% that the patient will develop or will progress in the diabetic retinopathy.
So I would say that if you keep your A1C less than 7%, diastolic blood pressure less than 80 and LDL less than 80, there are less than 5% chances you may develop any microvascular or macrovascular complications. I, as a physician, always say that retinopathy, nephropathy, and cardiovascular disease goes hand in hand. But two of them are microvascular, one of them is a macrovascular, but all three of them goes hand in hand. If macroalbumin is positive, retinopathy will invariably be there, and if macroalbumin is positive, there are chances the patient will have an underlying coronary artery disease. Therefore, do not forget to get the microalbumin test, which is now called moderate albuminuria. The term has gone, that the albumin levels in the urine more than 30 milligram per cell. So if the microalbumin or moderate albuminuria is positive, don't wait for macroalbuminuria or the severe albuminuria to develop in a patient with diabetes. My another question is that can a person with impaired glucose, that means he is not yet clinically diabetic, we know that a fasting blood sugar of 90 can have a cardiac involvement. Similarly, how many percentage of cases of pre-diabetic will develop diabetic retinopathy?
So pre-diabetic levels, we hardly see any cases developing diabetic retinopathy. We can put it in the bracket like 5% around 5% of cases can develop diabetic retinopathy if it is a long-term impaired glucose. Otherwise, it takes time.
Okay, so diabetic long-standing duration of diabetes and hyperglycemia is required to develop retinopathy with that. So in diabetic retinopathy, what else a family physician can do, and what are the earliest symptoms of diabetic retinopathy? Symptoms of?
So the earliest symptoms of diabetic retinopathy is the blurred vision. Patient can see the things blurred. Patient can have metamorphopsia. They will see the things that they are not the size or the shape which it seems to be, and then they can have black spots which we call as floaters. These are the early symptoms that we need to look into, and would advise every patient that if these kind of symptoms develop, don't wait for the follow-up date and immediately come back.
So this becomes like an emergency, that if you are suspecting, if your patient is having floaters, don't talk about that the doctor has given me a time for a month or a 1 day or 1 week's time. Go to your doctor immediately. So this can be taken as we always say anything unusual, anything for the first time, and anything which cannot be explained. Go to your doctor. In terms of diabetic eye, it becomes a floater. So if you see any black spot in front of your eyes, go to your doctor immediately. What is the link of diabetes with cataract and diabetic with glaucoma?
Diabetic patients are prone to having early cataracts as well as glaucoma. They again at the age group also are indicative of the same thing, and diabetes per se lead to early formation of cataracts.
So the message to end is that keep your diabetes under control, keep your fasting sugar less than 80, A1C less than 7%, ideally 6.5%, and don't be afraid that if you need insulin, shift yourself to an insulin. Now, effective treatment can be oral plus insulin. We know that 10% of the patients every year will have a failure of their drugs. So maybe in 10 years time, you may end up in taking an insulin. By hook or by crook, whatever you do, keep your A1C under A1C, LDL cholesterol and blood pressure under control. People say, should I go to homeopathy? Should I go to Ayurveda? Should I go to... Wherever you go, objective is 3 together. That we need to keep your A1C levels, lower blood pressure and cholesterol levels in the normal. It has been seen that one drug category will reduce your sugar by 80, not more than that. And there may be some drugs which may reduce your sugar only by 50 or 60. So therefore, multiple drugs with or without insulin may be needed. And it is also said that lifestyle management alone may not be able to prevent your, may not be able to control your diabetes. You may require drugs along with it. My last question is very clear. In blood pressure, we say, in hypertension, we say that if your hypertension is associated with any complication, target organ damage, That means blood pressure is associated with LVH, blood pressure is associated with LV dysfunction, blood pressure is associated with retinopathy, blood pressure is associated with nephropathy. Then lifestyle management alone will not work. You need antihypertensive medicines for life. Similarly, in diabetics, if you develop any complication, that means the diabetic with complications, lifestyle management alone may not work.
Completely agree, sir. Lifestyle management is the last thing in the mind when we talk about diabetic retinopathy. When diabetic retinopathy develops in the patient, he has already passed the stage that the lifestyle changes alone will help. So the drugs has to be complemented with the lifestyle changes.
And the important thing to remember is that diabetes retinopathy would mean nephropathy, and sometimes with the onset of retinopathy, you may find that the blood sugar level goes down. That doesn't mean patient's diabetes is disappearing. That means nephropathy is arising. So let's go back with a couple of messages today. And the message is, diabetic means you need to have a diabetic retinopathy checkup. Once in a year, at the diagnosis of diabetes, get the person's eye checkup done. There may be that he has a proliferative neoangiogenesis of his eyes, and if that happens, it can cause symptoms which can lead to ultimately blindness in the person. So don't ignore if you have a diabetic patient or if you are yourself diabetic. A doctor may also be a diabetic. Right? Take out your diary and see when did you last visit your ophthalmologist. And all GPs who are watching this program, try to find out, talk to your colleague ophthalmologist, try to find a low-cost fundus camera, which may not only help your diabetic patients, but also other patients of hypertension. So that, like in ECG, every GP, a time will come, we will have to keep a fundus camera with him. And remember, a time is going to come, people are going to sue us that why you did not control my sugar in time, why did you allow my retinopathy to progress. Let's thank Dr. Shashank to be here with us. And of course, if you like this program, if you feel this program was useful, worth sharing,